but I have no problem talking. Speir will attest. I'm Liza Szelkowski. I was going to start by saying I'm the only one who's not a nurse navigator here. I'm actually a full-time practicing physician assistant in cardiac surgery. But in listening to a lot of the things that everyone is doing, I think a lot of the things that they're doing, we're kind of incorporating into our job actually as seeing the patients at the bedside. We do have our own nurse navigator now. Julie Kim is back there somewhere. Her role is relatively new. The last several months it's kind of been evolving. And when all of this talk about trying to reduce our readmissions came up, I sort of got delegated by one of our surgeons to sort of look into it. So like everyone else has been saying, kind of tore the process down, and when we looked at it, we realized that we really weren't doing a lot of the things as well as we thought we were doing, or at all. We realized that we were giving patients a ton of information in an attempt to educate them, but we were giving them too much information and several pieces of paper saying sort of the same thing 50 different ways, and basically they were kind of leaving the hospital completely confused. When I kind of tore apart our discharge packet, which is where I started, I realized we had stroke written on 3 different papers and discharge instructions on 2 different papers, and then the after visit summary from Epic was populated with so many things that I said I'm embarrassed to say that I usually just write the discharge order and hand it over and hit print. And people have said, you don't read it? I said, no, I don't read it. I trust that but when you actually read it, it's pretty embarrassing what you were giving your patients. And no wonder they have no idea what they're doing. So after looking at that and streamlining that, we've actually streamlined our discharge packet quite a bit. It was actually 2 folders. It wasn't even just 1 folder. It was 2 folders full of papers. And so we basically kind of streamlined it to the after visit summary, and then a few things, a paper on stroke, a paper on cardiac rehab, our actual discharge instruction paper. And something that we started that was new was we also realized that nowhere in the discharge instructions did it say what you had, what operation you had, like anywhere. Like it wasn't written anywhere. Why you were in the hospital was not really written anywhere. It usually said like not populated under in the after visit summary. So we looked at that, and I created a document that we kind of put in the patient instruction section of the Epic discharge, which says my cardiac surgery lists what surgery you had and then explains it in layman's terms, why you need it, where your incisions are, because nobody knows where their incisions are either, and then we drew them a picture. So I kind of got a picture of the heart and kind of drew it out, and now we attach a picture to that, drawing all the graphs they had if they had bypass surgery, or circling the valve if they had valve surgery, to actually give them an idea of why they were in the hospital. So we kind of started there. We realized that we had a lot of inconsistencies in our discharge teaching and education. We had sort of a lot of turnover on our step-down unit as far as getting a lot of new nurses in. So we have a lot more stability now. We have a great nurse manager. We have our navigator, Julie, who's been a huge help, and a couple of nurses who they put in supervisory roles. And between them, we're really trying to standardize everything. Julie has created a discharge kind of cheat sheet for the nurses to make sure all the teaching is done the same way. A cheat sheet. Yeah, to make sure that they're all kind of covering the same things. And actually, we're going to start with a discharge ticket pretty soon too. That's going to sort of be an official checklist that we'll staple onto the discharge packet to ensure that everything's covered, and then everyone kind of signs it to make sure that everyone's on the same page. Regarding the education, same thing I think Pam was saying. We were kind of throwing it all at them an hour before they went home, realizing that once they got home, they weren't really remembering anything that we had told them. So we've really started, first of all, changing things into more of a teach-back format. Julie's also created kind of a patient quiz while they're sitting there, doing nothing, watching TV, to sort of go over, start answering some of these questions for themselves. And then she actually goes in as soon as the patient hits the step-down unit to start, going over the education process with them. So we at least have a couple of days to reinforce. We send people home I think fairly early, sometimes as soon as post-op day 3. So sometimes our patients only have a day or 2 on the step-down unit before they go home. So it is a lot that we throw at them. So that's where we went with that piece. A lot of other peripheral things. We created a patient welcome letter, which should be, I think it's in its final version now, unrolled fairly soon. The more people you have read it, the more people want to change it. So after having a meltdown over that last week, I decided to pick it back up and finish it today. So that will be rolling out soon. But we also realized that we never really, when patients get preoperative evaluations, we used to do them ourselves as the physician assistants. Now it's in the office, our nurse practitioners do it, or we have 2 nurse practitioners that do it in the hospital, but they don't take care of the patients after surgery like we do. So there's never anything really written down about the journey and what your journey is going to be after cardiac surgery. So that's sort of what we wanted to do with the letter, sort of introduce ourselves and kind of tell them a little bit of what our expectations would be, and to try to engage them too, to be an active member of their recovery rather than us just kind of throwing at them what to do. So that's going to be starting soon. The other thing that we really changed was trying to increase communication after the patient leaves the hospital. So we decided that we want to make sure everyone gets a phone call 24 hours after discharge, and Julie, our navigator, is doing that along with the supervisors. I created a template for that so that everyone's sort of doing it in the same way, and then we can track it in Epic. And if they identify any barriers or problems, then they know to follow up, make sure to touch base with somebody to try to catch it early on, make sure the patients got their medications, make sure the follow-up appointments are made. We're actually starting to make the follow-up appointment with our surgeon's office, which is a new thing for us. We always said make an appointment in, it used to be 7 days. We've actually backed that up to 5 days now. So they're getting a phone call 24 hours after discharge, and then pretty much all of our patients that go home get visiting nurses. If they don't go to acute rehab, we try to send our patients mostly to acute rehab or home, obviously home, if possible. And so we've really tried to partner more with our visiting nursing companions, and Inova has its own visiting nurses association. So we've kind of started a pilot program with them just because they're obviously accessible to us, in the hopes that we can spread it to the other agencies, because they probably only see about half of our patients that go home. But we've created a template. Also, one of my colleagues created a nursing assessment template that we want them all to use, so they can all kind of chart on our patients in the same way. She's actually my colleague, Janine Quatman. She also put together a PowerPoint, or like an hour-long presentation for the nurses. She went to their meeting. We're trying to educate them, starting with a kind of a small group of them to see. We're focusing on, obviously, the hospital is focused on the Medicare CABG patients, but Dr. Speir has, been adamant, as have I, that we want the same care for all of our patients. So we're doing it for everyone. The visiting nurses are kind of being trained and starting on the CABG patients because that's the one that the hospital is most concerned about. But they're all getting the same assessment, and that was something that was really important to us, to make sure that we weren't just focusing on that one group. But having them, we actually had the visiting nurses come and spend a few days with us, see what we do clinically, show them how we assess wounds, show them how we assess patients, to try to just educate them more. And they were loving it. They had, they were really eager to learn. And our hope is that, once we can train them to obviously get to everyone else. So in doing that, we just wanted to try to create a chain of command from the 24-hour phone call, and then the visiting nurse will be able to access that. We've had some issues because they chart in a system other than Epic. And then having their assessment at 48 hours available to the nurse practitioners in the office when they're seen in 5 days. So we can really kind of keep track of them, especially for the first several days. It seems to us a lot of our patients go home and come back. They're going to come back in 2 or 3 days. So we kind of felt the more we could stick with them in that first several days after surgery, the better that we would be. So that's kind of where we are now. We have a lot of lofty goals. We're also trying to get a patient class, preoperative class, in order just to try to educate them. And I know one of my other colleagues is actually working on a patient experience video, sort of detailing the whole process that way. And our hopes would be in the future to offer them perhaps either the class or the video, whichever their learning style they think would fit best for them. So that's kind of where we are.
Debbie,
Thank you, Liza. Thanks for jumping in and representing Inova tonight.
Can I just make one comment?
I don't want to belabor this, but at the risk, just to mention to the physicians in the room, Liza just gave you sounds like total chaos in a particular program. And let me just say categorically, for those of you who may remember, 2 years ago we had decided that readmissions was going to be our targeted focus for 2016. And so you may remember Debbie came down from Joint Commission and gave an overview from the Joint Commission perspective on things that they were looking at with readmission and then some of the protocols. And then we had the Centera group that had the lowest readmission rate in the state share with us what they did. And we implemented 100% of those. And really felt like that we had done a good job, and we were all patting each other there on the back. And actually Linda would show in the STS perspective our readmission rate was very low and acceptable. And then we started getting the reports back, as you may or may not recall, about 8 months ago from CMS, and ours was about 2.5 times the STS number. And we said that can't be right. Well, it was, because obviously the patients were being readmitted in other sites. And then as we went back, and as Liza described to you, what I thought and what we as the physicians had thought was in place over time had totally fallen apart. And we just, it wasn't that we were asleep at the wheel, but we just taken for granted that the protocols, the procedures, the written data, and what was being given to the patient was the same. Well, we've got about 5 different quality teams, I don't know about your hospitals, that are unrelated to each other, that they were all coming in and giving input. We'd had an extraordinary nursing turnover with different levels of nurses, predominantly newer, less than 4 years. I think, 70% of the nurses at Inova now are less than 4 years. And so with all of this turnover and with all of these